Good afternoon, everyone. My name is Khristian Erich. I'm an MD PhD student in Dr. Longacre and Dr. Hume's labs, and I'm very excited and privileged to be able to present our work looking at the role of creeping fat in intestinal fibrosis. So I still remember the day when I got my first patient sample from a patient who had an ileocystectomy for a stricture. And as many of you know, these patients, first of all, present with Crohn's disease. And when you receive the sample, what's very noticeable is that it's very stiff and it's surrounded by fat. So here on the left side, you can see what these strictures look like in the operating room. But what was very striking for me was that if we went distal to proximal in the direction of the stricture, the bowel wall started to get really thick and fibrotic, and the extent of the mesentery started to wrap around even more. And we know this as creeping fat. And so it suggested that there was a relationship between the expansion of mesenteric adipose tissue and fibrosis. And in fact, it's estimated that anywhere between 90 to 95% of Crohn's disease strictures present with creeping fat. And so we often use it as a marker for these lesions in the operating room. And so just to give you an overall perspective on the clinical burden of this disease, there are 3 million Crohn's disease patients, upwards about 20 to 50%, who will develop a stricture at some point in their lifetimes. And 80% of these patients will require surgery at any point in their lifetime. And what's very striking to me is that 30 to 70% of these patients will recur even after surgery. And so despite advances in biologics, stricture incidence remains relatively unchanged, and there are currently no antifibrotic therapies, suggesting that there may be other mechanisms in addition to inflammation that contribute to stricture progression. And so we wanted to ask the question, given the intimate association between creeping fat and intestinal strictures, what is the role of creeping fat in intestinal fibrosis? Is it simply just a passive bystander, or does it play a more nefarious role? And so we hypothesized that there may be a subset of mechanosensitive fibroblasts that are present in creeping fat that contribute to intestinal stricturing. And so you've heard in previous presentations that recently there's been a greater appreciation for the presence of fibroblast heterogeneity, specifically the presence of these mechanosensitive fibroblasts that are thought to respond to mechanical cues from the microenvironment. And so we at first wanted to tackle this question by understanding, what does the world know? And so we generated a meta-analysis of all of the single-cell Crohn's disease studies that we could identify, both in adult and pediatric patients. And we took samples that included both the bowel and the mesenteric adipose tissue. And we came up with a hodgepodge of different disease conditions and states. And so we were initially a little skeptical about being able to pull out these profibrotic fibroblasts. So what I'm presenting here are the results of this meta-analysis. We were able to identify the fibroblasts, and we were able to identify in particular these two subpopulations of fibroblasts, CTHRC1 positive and LRRC7, that appeared to bear mechanosensitive signatures. And the way that we determined that was, first, we looked at the YAP signature, which represents YAP target genes. Then we looked at whether these cells have the components to perform mechanotransduction via the YAP-TAZ pathway. And finally, we looked at the presence of ECM gene expression in these cells. And lo and behold, we were able to determine that it is in these two cell populations that are particularly high in these signatures. So next, we wanted to ask, where are these fibroblasts actually located? And so what we were able to find was that they're highly present in the stricture condition, but in particular in creeping fat. And that was very exciting for us. And you can appreciate that expansion here showing in creeping fat the presence of these mechanosensitive populations. And what was even more fascinating was that it appears that fibroblasts in the mesentery are particularly attuned to mechanical signals. And so that was obviously an initial starting point, but we wanted to know, where are these fibroblasts located in the tissue themselves? And so we hypothesized that mechanosensitive fibroblasts actually occupy profibrotic niches. And so to understand the spatial architecture of intestinal strictures, we took a multimodal approach whereby we incorporated the ECM ultrastructure algorithm that you heard from Jason previously, spatial transcriptomics via Visium, as well as our own data set of pediatric Crohn's disease strictures. And so we divided the strictures into various domains: the bowel wall, the creeping fat, and this fibrotic stroma in between the two, which we denoted as the interface. And what we were able to find was that in the interface, it's highly enriched for extracellular matrix remodeling, YAP-TAZ components, as well as YAP target genes. So when we performed the ultrastructure algorithm, it was very striking to us, using the same histological domains, that it's really at the interface that a lot of this fibrogenic processes are occurring. So next, we decided to map where these fibroblasts are located using our single-cell RNA-seq data. And what we were able to find was that these profibrotic fibroblasts are present at that interface. And this was confirmed via immunofluorescence using different markers of that population. And then finally, we looked at a subset of these mechanosensitive fibroblasts, which express clusterin, which is a marker of profibrotic fibroblasts that we believe are present in creeping fat. And we were able to show that that these profibrotic fibroblasts associate with smooth muscle cells, and that they also correlate spatially with profibrotic genes. And so we've reached the limit of what we can do in the human setting. So can we actually model this process in the mouse? And the biggest drawback right now of a lot of inflammatory bowel disease models is that they're not able to produce significant amounts of fibrosis. And in particular, no models reproducibly create creeping fat. And so we took a surgical approach whereby we create a colotomy, and then we close it under high amounts of tension. And so what we were able to find was that specifically in the areas that we created a colotomy, so here I'm showing you two different colotomies that were created in the same bowel, the fat actually starts to creep around, which was very exciting for us. And in some of our samples, we were able to achieve 50% coverage of the bowel, which meets the criteria for creeping fat. In addition, we noticed an increase in trichrome positive area denoting collagen, as well as muscular as propria thickening. And then finally, it was very exciting to see the formation of this kind of pseudo interface between them, suggesting that we're able to recapitulate key features of human strictures. But now back to the main question, which is, where do these fibroblasts actually come from? So we altered our model in a little bit by actually grafting a GFP positive mesentery onto a GFP negative mouse's mesentery. And then we created the colotomy, and then we asked the question, can these fibroblasts actually creep into the colotomy site? And lo and behold, they do. So you can appreciate here in the colotomy that there is this infiltration of profibrotic mechanosensitive fibroblasts, as evidenced by the presence of nuclear YAP, which was very exciting. And then finally, in the human setting, we tried to correlate it with the presence of clue-positive mechanosensitive fibroblasts, which we believe are almost entirely present in the creeping fat and that interface. And then lo and behold, we see the stromal infiltration into that interface. And so we believe that what's going on is that creeping fat contributes a stromal mechanosensitive fibroblast to the formation of this interface. And this leads to an increase in fibrosis and stricture progression. And so why is this significant? Because I believe that it's important that we not only target the fibrosis in the bowel, but we may also need to target the pro-fibrotic inflammatory environment that is present in the mesentery as well to be able to tackle intestinal strictures. So I hope I've provided some evidence that there are mechanosensitive fibroblasts that are present in creeping fat. And we've developed a novel mouse model of intestinal fibrosis that I've utilized to show that creeping fat-derived fibroblasts, at least in our mouse model, can participate in fibrotic processes. And so finally, we hope to be able to use more specific lineage tracing systems, such as a liposome encapsulated 4-hydroxytamoxifen, to inject into the mesentery and see if we can recapitulate those lineage tracing results that we saw earlier, and then to be able to knock out YAP in the creeping fat. And so with that, I'd like to acknowledge Dr. Longacre and Dr. Kuhn for their unwavering support of this project, in particular for Ben, for this incredible work that he's been able to do for us, for John Liu and Mike Janicek for their incredible meta-analysis pipeline that they've developed, and I'm happy to take any questions.